Hi, welcome to Cardiac MRI Simplified at mricardiac.com. We're looking at the 173rd case titled Microvascular Dysfunction in Hypertrophic Cardiomyopathy. This is the first time I haven't used a funny or a pithy title because I really just couldn't come up with anything. Anyway, this is a 63-year-old man with hypertrophic cardiomyopathy who had chest pain and discomfort and had a normal coronary angiogram. So, if you look at the Senese, there's classic asymmetric septal hypertrophic cardiomyopathy, and it had that classic extension along the mid-inferior wall to the apex. There is a little bit of SAM, but there's no real LVOTO, and all of this is modified by the AR that you see here, which is hitting the anterior mitral valve leaflet. There is fibrosis, typically, as you would see with HCM, one focal area of scar formation, and this involved about 11% of the myocardium. Now, because of the chest pain, the patient had an adenosine stress MR done, and you can see here this non-territorial, almost ring-like subendocardial ischemia or defect, which is better appreciated on these static images here. And this wasn't appreciated on the rest images. So what you're basically seeing is inducible ischemia. So if you look at all the findings, we have asymmetric septal hypertrophy, mild SAM, no LVOT, or mild to moderate AR, inducible non-territorial ischemia, about 11% fibrosis. So that, in short, summarizes what we have. Now, what do we look for in patients with HCM? EF and mass measurements of all the segments, especially their end-diastolic wall thicknesses, the position of the papillary muscle, SAM, LVOTO, MR, fibrosis, and when it's the apical phenotype, infarction, aneurysm, and then the mid-cavity obstruction that occurs as a result. But we don't really look for microvascular dysfunction. Now, we all know that HCM involves myocardial cell disarray and fibrosis. And within that construct, therefore, it's always been assumed that there is microvascular dysfunction and ischemia, but there hasn't really been a way of showing it. So we've even got studies on diffusion tensor imaging, etc. But the best bet would be something like adenosine stress MR, which can quantify blood flow. Now, when I did this as case 109, and we talked about apical aneurysm, and you can see this infarct here, which is because of the ischemia and the microvascular dysfunction. This was based on this article by Rebecca Hughes, who did quantitative stress perfusion in patients and found 100% every patient classified to have apical HCM had significantly reduced, and you can see that here. I've taken this image, had significant ischemia. And that's why, and we've seen that in our patients as well. We don't do adenosine stress perfusion, but we've seen this typical configuration of an aneurysm, which would suggest that this has occurred because of infarction in these patients. Now, in that study, they looked at patients with asymmetric septal hypertrophy as controls. And in those patients, you can see the second row here, they've also found areas of ischemia, the same as in our patient. But they haven't spoken or written about this in any more detail. But clearly, therefore, patients who have non-apical HCM would also have perfusion defects and reduced blood flow. And these are important components of HCM, whether apical HCM or otherwise. So if you look at adenosine stress CMR, it is the best method to address ischemia and microvascular dysfunction. And I addressed it in case 83, just to show you, patient had this RCA territory infarct. We showed inducible ischemia in the LAD territory. Nothing was done. 5 years later, the patient comes back with a full-blown LAD territory infarct. This was predicted. So there was this one paper in JCMR that did adenosine stress MR in patients with HCM and found 40% of them having ischemia, but many of them also had an apical aneurysm where you would anyway expect all of them to have ischemia. But the non-apical HCMs also had ischemia. So it is likely that microvascular ischemia dysfunction is an independent risk factor. And then perhaps in the future, we may be doing quantitative adenosine stress CMR. But, for that, a lot of research needs to be done. A, how reproducible the technique is. B, what does it mean for the patient? Three, is it truly an independent risk predictor? Four, is there a treatment modality available that would address this to reduce the risk? Is it even worth studying this, etc.? But we're here for the next 2, 3 decades. So I'm sure I'll address this in the near future. My WhatsApp channel, that's the book that started it all. My book that I published last year. And thank you so much for listening to me.